All right. Well, good morning, folks. We've got a small group starting to trickle in here to another Friday discussion of extracorporeal therapies. Hopefully, we've got some interesting stuff floating around out there that we'd love to hear about, chat about, whatever level, even if you're thinking about getting a unit off the ground or you're 1,000 treatments in this year. It's always nice to just hear how things are going for other folks. Um, so that Cedric and I don't monopolize the time here. So I think we're both going to be trying to pick on folks to try and unmute and take your cameras off so that we can learn from each other. As always, I'm Jethro. I'm out at Cornell, directing our extracorporeal therapies unit here, and co-host who is looks like he signed in twice. So we'll see where he gets to. Cedric Dufayette, who's down in UC Davis in San Diego, and running the program down there. So with that, Eclipse is signing in here today as well. Oh, there might be some good stuff coming from Eclipse. Ben, is that you in the background there at Eclipse?
Nope, Ben's off today, but it's Carrie Hemmelgarn.
Hey, Carrie, how are you doing today?
Good, how are you?
I'm all right. How's your practice going down your way? You're
It's
just
good.
any cases that you've got going on right now?
We had a AKI dialysis that we did for 2 weeks. We stopped that last week. The owners ended up stopping and we euthanized. But we've been doing like a decent amount of hemoperfusion.
Yeah, you guys see a lot of toxicities from what I hear and understand. Is that right?
Yeah, we do. It like it's a fairly central area, but right now consistently we're the only practice that's doing it in New York and New Jersey, Connecticut. So we're getting like a decent amount of referrals for toxicities.
Nice. Um, do you have a little bit in your back pocket to tell us about that AKI and kind of the course of things?
Yeah.
Yeah, that'd be great to hear about.
So his name is Axel. He was a 10-year-old intact pit bull. We the good news for him is that we actually had fairly new previous blood work prior to his AKI. So we had a pretty good idea of when it actually started. He had blood work from February that his kidney values were normal. He had just standard wellness blood work in February. He had been chronically on carprofen for arthritis. And then essentially he um, had some time period being worked up from his primary vet for some vomiting, not eating, and it ended up being noted presumptively that he had pancreatitis based off of elevated amylase and lipase, but no ultrasound. He had been managed a few days outpatient, getting subcu fluids, Serenia, either lack of talking to the primary vet or he had continued to be getting his carprofen despite not eating and having some fairly significant GI upset. So he was managed for a few days outpatient. When he wasn't getting better, they rechecked blood work and had noted that his baseline creat, which was 1.5, had gone up to 9.4. And that's when he was referred over. He had an ultrasound that did show fairly significant pancreatitis and an AKI in his kidneys. So suspected probably multifactorial secondary to pancreatitis, but also probably, unfortunately, NSAID use concurrently with his pancreatitis. So he was managed for a few days through our internal medicine service for pancreatitis and AKI. Initially, he had not had a urinary catheter in place, but it seemed to be assessed that he was making urine, but it wasn't initially quantified whether he was oliguric or anuric. He wasn't anuric, but it wasn't qualified whether he was polyuric or oliguric. He also was somewhat of a difficult individual to manage. He got normal. He was lepto witness tested negative. He had a UA and a urine culture sent out that did not show any growth. And he was managed for a few days with pancreatitis. His kidney values weren't necessarily worsening, but they had plateaued in the 11s and weren't getting better. And he was gaining some amount of weight. So the owners elected to move forward with hemodialysis. He was never particularly hyperkalemic. I think the worst it got was 6-1, which was like 3 days after one of his dialysis sessions, but he was never hyperkalemic and he was never anuric, but he was subjectively overhydrated and wasn't responding to fluid therapy. So he had already had a feeding an NG tube placed by the internal medicine service. So we did his first day of dialysis. We have a Phoenix machine. So we did his first day somewhat conservative. Like his URR, I'd have to pull up like his exact numbers, but he tolerated treatment pretty well. His creat went from 11.6 to 6, and we got off about 2 kilograms of body weight with ultrafiltration, which he tolerated fairly well. We did have we had an issue with our crit line that we weren't completely convinced that the crit line was working or whether the dog was intermittently not tolerating the ultrafiltration. And so we did some time period, do some minimum UFR and then go back into ultrafiltration. And it tended to do well if we gave him like 10 to 15 minutes of being off of ultrafiltration and then going back and he would tolerate it. Actually, one of our previous technicians had been doing an extern. She's now vet student at Penn, but she was doing an actual externship at Friendship at the time. And so we had had her ask JD sort of what he had thought of some of the air messages we had said, and he had sort of given the advice that he thought that the ultrafiltration was just a little bit too much. And so we did back down on it, and it tended to respond a little bit better. So he ended up getting a total of 8 dialysis treatments. Initially, he got them daily for 3 days. Then we went to every other day. Then he would go home at night and come back. And then we did like 1 or 2 treatments with it 2 days in between. And then we tried to get him through a weekend without treatment. And he subjectively did okay for a day or two, but then stopped eating and stopped doing well. And we really saw no renal recovery. And so the owners elected to stop after it was like 18 days into dialysis.
Oh, well, I hope he enjoyed at least some of that time that you guys gave him that he wouldn't have had otherwise in the interim. I know it's hard to get that far into it and then have to say goodbye. It can affect the whole group that way. Um, I wonder, would you mind going back? I can open the floor for other folks if they had questions for you as well. But I was curious just to, you commented on your crit line changes that you weren't sure if we're telling you, something important about your ultrafiltration or, some of the challenges with that. Could you dive a little bit into that for us?
Yeah, I'm just having my nurse pull up his record one because then I can give people like actual like URR numbers, but there was an air code that I actually hadn't had on the Phoenix before. And so that was one of the things that we were trying to troubleshoot what was causing the air code. And the crit line was definitely showing more of a precipitous drop than what it had previously been doing. And so we weren't 1,000% sure if maybe there had been a clot in it or if it actually truly was associated with his ultrafiltration. And so I'm just his thing. He was also somewhat obviously difficult to handle. And so sedating him for some of this was also a challenge for us, just for the fact that he was a 100-pound, not particularly nice pit bull. So the original, his first treatment, just getting to the, it was saying a minimum dialyzer pressure alarm, which I had not had that alarm previously noted when it was that. And the Phoenix continued to move forward in treatment, and it wasn't stopping us from doing treatment, but that it wasn't going away, but it wasn't precluding us continuing to move forward with treatment. Also, all of his vitals were normal. His blood pressure had been holding steady during the whole time period. So we had talked to JD about it, and he had just thought that potentially that the ultrafiltration had just been too aggressive for him. And so we put him in minimum UFR for about 10 minutes, then tried to go back to ultrafiltration. The pressure was still alarming. So we gave him like another half an hour, 45 minutes on minimum UFR, and then went back. And then it was actually successfully able to continue the rest of his treatment in ultrafiltration.
Cedric, is that an alarm that you know anything about? It's been a while since I worked on a Phoenix platform.
So I'm sorry, I've got some connection problems. What was the alarm exactly?
The alarm was the minimum dialyzer pressure alarm.
Yeah, I've had that one, and I don't always know how to solve it actually. Um, it's just like what was your ultrafiltration rate at the time, and did you go into the machine settings to check your TMP as well?
We did not check our TMP. The ultrafiltration setting is our goal was 2 kilograms over a 5-hour treatment. So it wasn't a particularly overly aggressive, but it was his first treatment. So and he was overhydrated. So we were trying to do some level of ultrafiltration. And so his treatment was supposed to be ideally 0.4 liters an hour.
Okay.
Yeah,
And
because
you only had the alarm when the ultrafiltration was on. Like when you
correct,
went to main, it disappeared.
it disappeared, and then we gave it off for about 10 minutes and then and we normally sort of the way I had been trained is that normally we do about 30 minutes of minimum UFR when we first start the treatment before going into ultrafiltration. And so so this was probably about an hour and a half into treatment that we started to have this alarm. And it did improve after giving a few breaks of going into minimum UFR and then going back. And it did. And when we went into minimum UFR, his crit line did refill appropriately afterwards. And so it actually, after we had done that, it did seem like it was not an error on the crit line, that it was actually seemingly his volume status.
Yeah, I do think the alarm is not related to the patient, though it's more like a machine alarm. Um, so it has nothing to do with the fact that he was tolerating the UF or not, and with the crit line. I feel like I've had that alarm like every now and then without really understanding where it was coming from.
Okay. Yeah,
It's just like pretty random actually. Because like the few times I've had that, I went to see if my TMP was too high, like if my dialyzer was clotted, and if that could have been the problem, but I've never really identified that. And sometime during the same treatment with the same ultrafiltration parameters, I would be able to go back into ultrafiltration without having the alarm, without reproducing it. So don't have a good explanation for that one. I don't know if anybody else has experienced that alarm and found out where it was coming from.
It seems like in the subsequent treatments, we did a treatment the first day and then another one the following day. And our second day, we did not have that error message. So it really may have just been a random situation. It seemed like, because obviously JD is very smart, but he seemed almost immediately to know about the alarm and like sort of how we should troubleshoot it, which was very helpful. So, but it was, we were going to continue to move forward if otherwise we felt the dog was tolerating it and the machine was going to let us. But it did seem to resolve after some time period of going back to minimum UFR.
Nice. Well, that was solved on that first one and didn't come back on the other 8 treatments or 7
No.
treatments after that.
Mm-mm.
Sweet. Um, how one of the things that I'm always interested in, and one of the things that I highlight for the folks that I'm talking about going down this pathway with is that 2, 3, 4 weeks. When is it enough time to know if there's going to be kidney recovery or not? And sometimes people just kind of reach their end at that 18-day mark, or where you guys were at after 8 treatments. But for me, it's the take home that I try and give folks is that they're usually feeling pretty good in between treatments. Did you find that as well? Was he doing okay on the off days?
It actually was surprising because the first 24 to 48 hours when he went home, he actually, the owners did describe that like he was very happy and was eating like on his own and like having a pretty good quality of which he had during the time periods that he was in the hospital, he would not eat for us and we were feeding him almost exclusively the tube feeding. The owner had also noticed that although he was an obese dog, that he historically did not have a great appetite for normal dog food at home. But they did notice for 24 to 48 hours that they did think that he had a very good quality of life. And then on that like 36 to 48 hour mark, they noted that he had started to like look swollen or like that he was starting to become edematous and was not eating his food. They were giving him his food, feeding him through his tube. And then like the last probably like 40 to 48 hours, he then started to have vomiting and regurgitation with the feedings. So they stopped. So I think that if they had truly been committed to a long-term, more chronic situation, we probably would have needed to get him in like a every like probably like every 48 to 72 hours sort of schedule. The other thing is that progressively with treatments, he was progressively getting more aggressive with the nurses, which was not great, but it was one of the things that we did talk about him being a candidate for more of a long-term treatment for the fact that he seemingly started to hate it more and more every time that he went through it. And so our concern was his quality of him coming multiple times a week with his perceived anxiety and dislike of going through dialysis. And so we did the last treatment, we had to give him like almost a continuous propofol CRI for most of it to keep him from not trying to attack the nurses during his treatment, which didn't seem like an amazing quality of life or could become obviously a safety situation at some point.
Yeah, that's tough on your team as well, right? I mean, I know everybody's heart is in the right place and they want to help these guys, but that's a lot to put them through on their side, as well as recognizing, the stress and challenge for the patient as well.
Yeah. And so I think so it was a combination of, we hadn't really seen much renal recovery. Also the fact that he was progressively becoming less thrilled with the process. And I think probably the last part was that by our 8th treatment, we were starting to have some catheter performance issues, and that the plan was if they were going to move forward, that we probably either needed to wire transfer another temporary or consider putting a permanent dialysis catheter in, just for the fact that our 8th treatment, we had a lot of catheter flow related issues. And so in the long term, it probably wasn't going to work for us to be able to use that as his long-term catheter.
Yeah. What's we dove into it a little bit the last 2 weeks ago, talking about catheter locks. But just out of curiosity, what would you guys lock your catheters with between treatment?
We do TCS.
Nice. Um,
And for the most part, we, like, knock on wood, have had pretty good success with minimizing catheter related infections. We had two dogs, like probably over the last like 6 years, we had two dogs that developed pretty significant clotting issues associated with it. One dog developed pleural effusion that was recurrent even despite pulling the dialysis catheter. One dog developed pleural effusion that resolved once we pulled the catheter and about like a week out, and had actually had renal recovery. And that dog, its pleural effusion resolved. But thankfully not a lot of complications, but we have had two more particularly difficult ones that clotted.
Okay. Well, thanks for sharing about your case there. And
Yeah.
yeah, that's those are always tough. I had my most recent, and actually we ended up losing him unrelated to extracorporeal therapy time frame, but was a similar age lab who also had just a little bit of uncertainty caused for his AKI, but he had that carprofen in his background as well. And it did not help that he started getting sick, and they still gave it to him, and certainly probably an additive injury there potentially. Cool. All right. Was there anything else, about it that, for the group's sake that you were like, man, this is something that I took out of this that, we'll kind of chalk up to knowing for the next time?
Yeah, I think the biggest one that we had was that that was like a pressure alarm that we hadn't that my technician and I hadn't troubleshot before. So I think that was like a big not like a big learning thing, but it was a learning thing that I feel like every once in a while there will be some error message or some pressure code that we hadn't seen before, and then are working on trying to see to troubleshoot it. And so I think that was probably the biggest thing that I learned from him is that new pressure code from the Phoenix.
All right. Well, if anybody is anybody feeling brave to unmute and ask any other follow-up questions? No. Hey, Chap, are you actually there in the background? Are you able to unmute? There he
Yeah,
is.
I am. How are you doing today?
Hey, good. How are you doing?
I'm good, good.
Yeah. Hey, I had a question for you. I don't know if this is the right time to put you on the spot without any prep, but
Yeah, for
do you guys still have your Aquadex platform?
We do. We actually haven't utilized it in some time. So we do have the platform handy, but I just it's very specific. And so we haven't had too many cases that we've had to think about breaking it out for. Just to jump into one that we had briefly talked about, it was a dog that was starting to become diuretic refractory, and they were trying to get it in for heart valve transplant and had a bit of delay in the timing. That the dog had gone into heart failure, and that we had looked into potentially sort of treating to buy us a little bit more time to get into heart valve transplant, but ended up with some adjustments to torsemide, being able to pull the dog through without getting to that level. So unfortunately, haven't had an opportunity to play with it for some time now.
And have you, one of the reasons I've been looking around and trying to figure out a better option for me for my smaller patients, And the Aqueducts, just kind of looking at the potential to do some convective clearance, even in a kidney type case with that smaller circuit size. Has that been anything that you guys have used it to apply for, or is it mainly for the primary function that it was built for, which was ultrafiltration?
Yeah, good question. Dan did treat one case prior to us getting the carpe diem, where we attempted convective clearance through that, and I think that it was a challenging case, so probably not a good one for him to jump into with the first time on the platform, which I think we can all sort of attest to experiencing some of those challenges. But the small circulating volume is certainly what kicked us off to that, because it was certainly a much more cost efficacious purchase, and so our thought process was, hey, can we use this in these small patients to get a slow treatment and balance fluid overload? Since I think we all see that relative fluid overload is a big component of what we see in a lot of these patients. And that was sort of the idea or thought process while we were trying to budget and save up for the Carpe Diem platform. And I think that, as we played with the numbers, and again, forgive me, it's been a couple of years, but in looking back at that, I think that it probably ties or piggybacks onto some of the challenges with the limited clearance that we get on these platforms, right? The goal or intent is slow, effective treatment over time. And when you're trying to balance out, doing a 12 to 24-hour treatment for a patient early in the acute disease process, staffing, how does that balance out with the sort of targeted goal of a slow treatment? And I think that, with the Aqueducts, looking at your convective efforts, I think you're probably going to reach some limitations to your sort of targeted clearance that you're only going to be able to overcome with increasing your time at treatment, which in the big scheme of things sounds great. And I think, us with that sort of criticalist background, like that slow, consistent, steady change. And I think we see that the patients tolerate that well. But to try to have enough staffing to do a lot of these longer treatments, I think is a little bit of a challenge, especially with a platform that you're not using routinely, to where we can have people that may have a lower level of training that become more involved with.
Yeah, that makes good sense. It is that trade-off, time, duration of treatments, person power, all of these practical things that really come into play here for us.
Yeah.
Um,
I'd like to ask Chap, what's your overall evaluation of the Carpe Diem in terms of uh, do you use it enough to make it financially justified, and does it do the job for you that you hope that it would do, and those sorts of questions?
Yeah, good question. I think that a lot of it is sort of almost trying to retrain our brains to it. I think that it's a pretty excellent platform that really we do end up treating a fair amount on. I think that having the flexibility of the platform to do membrane-based therapeutic plasma exchange really gives us an avenue to treat some of the smaller patients without consideration of blood priming. And I think that, that's probably with some of the decisions sort of made within our own practice to limit a blood bank, that has become sort of an increasing sort of consideration, is avoidance of blood priming and trying to find some of these small circuits that we can utilize to treat these patients with. So I'll say that I have a few nurses that despise the system, and others that sort of do love it, as long as we shift our mindset to say, hey, this goal or target is for a slow sort of treatment, which is what it's targeted for. I think that it is a versatile platform that allows us to do dialysis, some degree of hemofiltration, of membrane-based therapeutic plasma exchange. And, we can certainly get some convective clearance on some of these, though. Again, it requires us to be really on top of the machine and a little bit more tech focused for starts and stops that we get. Um, so it is, oh gosh, similar to probably what I equate to the Nova, sort of described as a Lamborghini that when it works really well, but it requires a lot of hand holding to get it through some of our treatments.
Great, thank you.
Yeah, no problem. Like you said, Larry, though, it is certainly a big financial investment, and I think that it's something that, when I look at growth of a dialysis program, we'd love to have all the toys, but it is a big financial investment that really does, probably even from our end of it, makes it nice to where we can take all of these phone calls and say, hey, yeah, we can really treat any patient size, and we have a multitude of options to sort of consider. And so I do look at it as a rounding out of a treatment platforms rather than an initial sort of purchase. But I'd love to hear if somebody else has done it differently.
What kind of service costs do they have on that service contract? Do you have to maintain a service contract, and is it the typical 10% of the purchase price per annum?
Yeah, fair question. We've actually taken the approach instead of paying for a service contract, just actually paying for the individual services and having them come out. I think we're doing that currently on a yearly basis. And that's actually been pretty cost effective for us. As the platform gets a little bit older, we may be regretting that decision, but that was the approach that we decided to take rather than paying for the full service contract. So I think it does offer us some versatility that they were able to work alongside us with that. They just had a system upgrade probably, 6 months or maybe 8 months ago, that they came in, and we just paid for the sort of service at that point in time. I don't recall or have quick access to those numbers of what the service contract cost is, though. I apologize.
To interrupt you guys, this is Carrie at Eclipse again. What is the sort of smallest patient that you've been able to put on the Carpe Diem?
Yeah, I was just looking through my case log here. I think I had like a 1.8 or 1.6 kg a patient that we put on the Carpe Diem. So it really gives you a lot of versatility with size. So you're looking at the 015 circuit is about a 32 mil circuit volume. And so, again, you've got some good options. I think the smallest one I have on my case log, I don't know if Dan and Karina had treated anything smaller, was trying to pull it up here, 1.6 kgs. So
Wow, that's very impressive. Thank you.
yeah, no problem.
Did you have to blood prime that patient though?
I know, I'm trying to get back to my notes. I'm poorly prepared and not rapidly pulling it up here.
Because you said 1.4?
1.6 is what it says right here. And so I'm trying to get this started up. I'm pretty sure we still did blood prime.
Yeah, because that's still like 25% blood volume, even with the 32 mils.
Yeah. No, we would have blood primed at that amount. So I just don't have my exact notes on what we did. I think with that, if I remember correctly, we did use, there we go. We did use a unit of plasma and a unit of packed red cells for that kiddo. And it can be a little bit tricky to, I think blood prime on the Carpe Diem is one that probably similar to some of the other platforms when we're using, some more packed red blood cells, trying to decrease that viscosity in the early stages you're doing the blood prime can help to mitigate some of the early alarms that you get and some of the clogging that you get through the filter as well. So I think that applies to this platform as it does for probably like the Prismax as well.
Yeah, that's, I'm in this next step ground of expanding our equipment arsenal on this end as well. And I'm looking at that exact trade-off. And again, maybe this is a simplistic way to look at it. If I've got to blood prime the Carpe Diem anyway, does blood priming Prismax, circuits. Am I gaining anything by having a different platform? And there probably are many other benefits to that smaller circuits in those patients, even if I have to still blood prime. Um, so I mean, maybe it's those like between maybe the 3 and the 5 kgs where maybe they don't need the blood prime on there, or somewhere in that range, that we're saving some of the exposure to multiple transfusions and the costs that go with that, and all of the other considerations with cross matches and the rest of it. But I know Eric.
Well, I think mine depends what over machine you have on the side. I mean, you might decide to go for the Carpe Diem without having the Prismaflex or Prismax. It just like depends on the strategy and how do you best cover your different patient. What is the type of patient that you see the most? Are you in a very rural area with bigger dogs, or are you in a more like city area with like maybe some more smaller dogs? I mean, I think you have to take everything into consideration. I think probably where the Carpe Diem can shine to me is probably for TPE, because at least in the US, I mean, we don't have a TPE circuit that is smaller than 126 mils, I think, for the HF 2000. The centrifugal is even bigger than that. I don't have a precise number for the Amicus, but it's probably around like 100 plus mils as well. So, I mean, definitely, I feel like where I struggle the most with smaller patients is more for TPE than renal replacement therapy most of the time. So to add that ability with the Carpe Diem, I think is a good option.
Yeah, the Amicus is 160 mil prime volume, where the TPE 2000 is at that 125 without a
Yeah.
crit line, right? So the TPE 1000s, like you said, we haven't been able to get those stateside, which is unique. And I think with the Carpe Diem platform, you're still looking at ordering those Plasmart filters from Italy, which can have some initial challenges, but I think those are certainly, it can be overcome.
And I think Medica has some other platforms they may be able to offer as well, apart from the Carpe Diem, for plasma exchange or even for CRT. Maybe I would have to go back, but and I don't know how many of those models are available in the US. That's always a problem too, is availability. But I mean, if we could get the HF 1000, I think I would probably be pretty happy with that, and I wouldn't look at the Carpe Diem.
Yeah, I've looked at the TP 1000 sets and thought about bringing them down because I'm close enough to the Canadian border anyway, but there's all kinds of other logistics with that. Um, but there's still, I mean, the priming volume still, I think 71 mils ish, somewhere in
I,
there.
I had 62 in mind, but I might be wrong.
Yeah,
Um,
I think it's
but it's
got.
just like it's such an improvement compared to what we currently have, though.
Jethro, what did you think of those Medica machines that I sent you the literature on?
Yeah, I was looking for the email from the connection there as well. Yeah, so Dr. Cago connected me with some of the folks at Medica, and they do have a smaller platform that looks like
Mhm.
it's quite promising in terms of the circuit size, with applications for plasma exchange as well as potential some kidney replacement.
And I should hasten to say that that's not the VetSmart. I wouldn't recommend that platform to anybody,
Yeah.
but they have a platform on their human side that I've seen at some of the meetings I've attended that I thought might be fairly attractive for veterinary medicine.
Well,
Well, I didn't make the math for that platform. Yeah, this one. I think the main attraction with that system via First Smart Plus is that the circuit size is fairly small, maybe not as small as on the Carpe Diem, but you can do TPE, but you also can actually do double filtration, or you can use it to do like plasma filtration, and there's a dedicated pump for that, so you don't have to fuss with trying to put your hemoperfusion cartridge on the plasma side and try to get creative about it, it's actually built in. So you can do either double filtration or filtration plasma filtration, and then put your cartridge. Yeah, the selective apheresis one. So if you use that configuration, it would be pretty easy to use like either a vet rescue or hematologic cartridge in your circuit on the plasma side for some applications, or any other like adsorptive device actually.
I think at least the last time I talked to these people, which was a year ago, they thought that they would have the machine approved in the United States on the human side by this time. I don't know whether it has been yet, but when I've seen the machine, I was fairly impressed with it for its
Yeah.
versatility and its potential application for veterinary patients.
Yeah, I'm not quite sure about the FDA approval. I think we're still in that type of conundrum where the FDA does not approve certain type of therapies, because there's like a fair amount of similar platforms in Europe and the rest of the world. I remember seeing a Braun machine when I visited the University of Pisa that was also doing like cascade plasma filtration or plasma filtration adsorption with several pumps dedicated to do that, and that was probably 10 years ago. So I wonder if it's just like the similar problem that we have with not having the secondary device software approved on the Optia, is that like FDA does not approve the adjunction of an adsorptive device for plasma treatments.
Yeah, but I know they'd be very anxious to get it in the veterinary space, I think. So even if
And
it's,
that might be a way to go for sure.
yeah,
Um,
and I think
I mean,
they'll have service opportunities in the United States. I think they already have people here that could service the machine.
Yeah, their plasma exchange bloodlines were about 60 mils, and
they have
pediatric,
some very small plasma filters for sure.
yeah, like 4.4 mils.
I think that actually those are the same plasma filters that you would use on the Carpe Diem, because again, that's the same company. And so when Chap was mentioning those little tiny Italian plasma filters, I think that's the one that he's referring to. So there are some pretty small ones.
Yeah, I think the Plasmart 100s that it will sometimes use are 8.6 mils, and the 200s are 13.2 mils. So it gets pretty small. Remember, you have to use that with the 025 circuit, though, because that has the Hansen connectors, that the 015 has a smaller connector. And that circuit volume for the 025 is about 22 mils on the Carpe Diem platform. One thing that I don't know if you guys have played with at all is trying to break into HF20 circuit and start to integrate some of these filters into that. So that might be an option if you have the Prismax platform, is to see if you can remove the HF20 filter and integrate like a Plasmart filter into that. And that might give you some versatility, because that circuit volume is 58 mils, right? And the issue being is that the circuit, I think, is right around 40 mils for that. So you're if you get like a Plasmart 200 in there, you're saving about 5 mils or so in filter size and getting a different performance with the plasma filter. So I don't know if that's something that would be worthwhile experimenting or playing with if you just have the Prismax or Prismaflex platform.
You know, I've thought about that, Chapin, and looked at those circuits, but those filters are glued in, so there's really, I think, no convenient aseptic way that you could probably break them apart and pull them out.
I mean, you might be able to put the plasma filter on a dialyzer on the blood side, because there you have some DIN connectors, and that's how we integrate the clear line into the circuit. But then all the effluent lines or dialysate lines, those are just like built in the filter. So there's no connection that you can just disconnect and reconnect on another one. So you would have to cut the lines and try to find a way to connect them to the new thing. So again, aseptically and for the safety of the circuit down the line, it's probably not the best idea.
Yeah, I've tried to break after we've used a circuit, tried to break into it, and is like a couple of glue, almost seems like a glue or just melted setting that does allow it to release on some of them. But there's others that are bound on there too tight to where, like you said, you'd be running into some issues.
Yeah, one of the things that keeps drawing me back to the Carpe Diem platform is just the flexibility in applications. The A for Smart Plus is primarily a plasma filtration platform. Having something
Yeah.
that can treat my small patients with kidney disease as well may lead me back, which is why I started, Chap, asking you about the Aquadex kind of first off. Just the quotes I got on that were a whole lot less than they were on the Carpe Diem.
You can get them on eBay for a pretty good price. I think that's what we the other thing to keep in mind, and I know we've trialed a couple of things, but the carpe diem is very sensitive, and so when you're looking at doing like plasma filtration and things like that, I've struggled a little bit with the platform because it allows such a minimal variance in your scale. I mean, that's and hence the safety of it for a small patient that you can certainly get some errors once you start to play with those scales that can certainly shut down a treatment. And so I think the sensitivity of it really has its a definitive need, but for trying to trick the system and different things like that, it's one that we've had success with, but then we've also had iatrogenic failures in the treatment too. So I think we just have to keep that in mind, is the small patient blood volume that they're intended to treat with results in a much greater degree of sensitivity when we start to play with our effluent scales and such.
Oh, thanks for sharing that, Chap. That's lots to chew on there, kind of looking at the next level.
Yeah.
Jay, are you on in the back there? Oh, sorry, Carrie, did you unmute?
That's okay. I just had a question. It's unrelated to what you guys were talking about. Do you guys have some sort of running like Google sheet or Excel sheet of different toxicities that have been treated with hemoperfusion, or something that we could access to look at different ones in case we came across that and whether someone had success or not? I know when we were doing the Academy, JD had people submit ones as part of a test question, but I don't think, at least what I saw in my email, that there was ever one that like we could add to help people, or that we could look at to help us if some weird tox. Obviously, we don't need 1,000 ibuprofen toxicities added to it, but if there was something new.
I think I don't want to speak for, I don't know if Polly or Jeff are on here. Um, I know that group shared with us the data that they had collected on toxicities and the various success for hemoperfusion on a fairly wide, like extended beyond NSAIDs. But that's the only comprehensive thing that I have that's even kind of a spreadsheet or in print that is beyond just sort of what we've kept at our own hospitals. I don't know if anyone else in the group has a repository that we can all start putting those, or where we are with that call out from when we worked on those projects as part of Dialysis Academy over the last few years.
Well, I'd add a little bit from my end. First of all, it's we often don't get the data, right? It's cost prohibitive to get data on all the patients and all the toxicities, and we do see a lot of one-offs. Like we'll treat something and then we won't see another one for 4 years. So what I've tried to do instead of making a list of the toxicities is characterize the toxin. And we're pretty good at predicting based on the characteristics of the toxin whether or not carbon will bind it. And in a lot of cases, carbon may bind it, but it's not available. So, time since ingestion, dose, a lot of the things that come into play kind of confound. I could give you a list, but that doesn't mean that you could remove it all the time. It really depends on the level of the exposure, the time since ingestion, all that kind of stuff. So it's a little bit more like teaching you to fish than giving you a fish. And so it's in the guidelines, in the hemoperfusion guidelines, characterize the toxin, and we can do with 97% certainty, we can tell you whether it'll work or not. So instead of making the list, because there's 20,000 drugs in the PDR, and then a whole host of natural toxins and household chemicals and all the other stuff that they get into, I think instead of focusing on the individual toxins, we need to focus on the characteristics.
Yeah, thank you so much for that input. I definitely understand sort of looking at what the characteristics and things like that. Our goal would be that if there is something that potentially is very off that people haven't seen before, it would be super helpful to see if people have had success and whether it did work or not for that particular one. But it also would help, particularly if people are looking for publications of things like case reports for certain types of toxicities that are more on the rare side, that it could link somebody up with some other institution that had that. And so I think and also if people are using products that are not your particular company's product, it sort of widens the variety of letting people be able to have a public space to put. Obviously, again, we don't need 10,000 ibuprofens, but it is something that if there are 3 cases of a particular very rare thing that we've done and it's been successful, it would be super helpful for things like publications.
Yeah,
I might just follow up on Jeff's comment about what we don't have is data. And if you run across a particular unknown or unusual toxin, and particularly if you're thinking about doing a case report, the most important thing for that case report is to have data on what you've treated. The hemoperfusion guidelines do kind of break down what we think would be reasonable data collection for just routine patient management, maybe a little bit more interesting patient management, and then what would really be important data to collect for something that you wanted to publish. And I think that's where that's the information we need for these new toxins or these new treatment opportunities, is to have people collect and measure the results of their treatment based on really accurate and credible data.
And I think just a comment on collecting that data, Jeff was a great resource for us on an Apoquel one that we're in the process of trying to write up. And I think just sort of utilizing that thought process of can we analyze our initial blood sample, maybe pick 1 or 2 before we sort of move forward. With the full testing, it can sometimes be helpful with the different groups to try to make it cost effective. So you're not, running all these samples on a patient that's largely decontaminated or something along those lines. Can try to make it a little bit more cost effective, but it's expensive for sure.
Yeah, and I certainly don't disagree with you. In a perfect world, we'd get data on every single patient and we'd have that repository and we'd, have that information available, but largely we haven't. And it is because it's cost prohibitive. I guess the last thing I would say, and Chap kind of hit on it, oftentimes, well, there's 2 things. One would be, the time since ingestion to the time of treatment, where you can see good results in a patient that was treated within 5 hours. But if you look at the same type of exposure in a patient that was treated 12 hours later, it was not so good. Um, so there's a lot of variables at play, and having having data without having all the variables identified. So you could look at the data and you'd say, oh, well, it doesn't work for that. Well, it's like, well, no, it doesn't if you wait 12 hours. So there, it's a complex subject, but you're absolutely right. In a perfect world, we'd have data on everybody and a repository, which I think at some point we'll have, but it takes a lot of time.
I think, however, if you're doing an intoxication, so the way I approached these when I was doing them, um, you wouldn't treat a diabetic patient without running blood glucose concentrations. And I think at a minimum, you should have a sample taken before you treat the patient and after you treat the patient, if for no other reason, for medical legal reasons. What if that client comes back and wants to sue you for some reason, and you would just be absolutely exposed if you didn't have the results of what you removed. And so I've gotten so I just include a pre and a post absolutely within the estimate for the patient. If they're not willing to do that, then go somewhere else and have your patient treated.
Well, I think the other aspect of that is just like if you decide to treat toxicity that is not well known to respond to hemoperfusion, then that's the type of case where you want to bank some samples so you could actually bring some data to the table and then be able to either publish a case report or at least communicate with the extracorporeal community what you did. To add to what Jeff just said, I think there are two ways also to look at the success of a treatment. There's obviously the patient outcome, but again, like depending on if you started to treat early or late, or a lot of other factors, you can actually have a bad outcome even if hemoperfusion was efficient to remove the molecule, or you can sometimes have a good outcome even if your treatment didn't do much. And it's very difficult to sort that out. And I agree that publishing a case report of a good outcome, if you don't have any plasma levels of the toxin you were supposed to remove, is kind of a moot point because maybe that patient would have done just as well without treatment. And as far as samples, I think the pre and post treatment samples are interesting, but also having just a pre and post cartridge, at least at the beginning of the treatment, is paramount because you might show that the exposure was not that high or that your patient didn't do well because you treated too late. But if you've got a pre and post sample, you might also show at the same time that despite the fact that your patient didn't do well, there was a significant extraction through the device, and that maybe with another timing we would have been more successful. So that's just like the two things. You might have a bad outcome because the timing was wrong, but if you show that there was significant removal through the device, that just gives information on the fact that maybe by treating earlier, we would have a different outcome. Or maybe it's just that we're very efficient at removing the molecule through the device, but the volume of distribution of a molecule is so huge that we're just barely making a dent into the overall burden of the patient. But as long as we don't have numbers, I mean, it's very difficult to make a story out of those. So
I think some of these numbers are coming though, and what I worry about
yeah,
is there's nowhere. It's like when exotic medicine started, there was a great formulary, and at least in that formulary, it said, "This is expert opinion. I have a published study on that," like so that you could make decisions, right? You could at least look at that and say, "Okay, I'm gonna, as a clinician, knowing what's out there, there's the don't even bother if, it's X amount of time, and I know some of that, like to Jeff's point, it is a little bit like fishing, but I think some of us don't want to be fishing with the wrong device if it's never gonna work, so is that like this is going to be a, hemoperfusion or like no. And again, I think that's growing. There's so many things that we can do. But for those of us, if you look at the time it takes from getting data to publishing data, we're going to be so far behind. Like we just did
yeah.
a great aspirin case. We got pre and post samples. We have that. It worked. It pulled it out. we want to publish that too, but also we want to share that so that other people can be like, oh, because some of the earlier stuff made us feel like we couldn't use hemoperfusion for aspirin, and then we sort of realized that we, you know what I mean? Like our own journey, like what we'd have told somebody 4 years ago, we would have said, no, we can't because we were under misinformation, and now we have more confidence and more information. So how do we share that forward in some sort of even informal ways so that the data that we do have, people
Yeah.
lean on that and say, okay, well, this is at least the data we have. I'll still make this fishing decision based on all the factors, but I have a little more confidence because I can borrow someone else's data till it's published.
And I think it's a project that's been around like for quite some time, but it's a huge task, and different groups have tried to tackle it. I think definitely, well, these rounds are one way to communicate early results for sure and share with the community. But then we need the publications as well, and we definitely need to have some numbers. And as I see that we're like at the end of the hour, that's actually the perfect segue, because I mean, I don't know if that's the case for you guys, but we have a lot of calls for apoqual toxicity lately, either like just after ingestion or when the cat or dog is already in acute kidney injury. And there are different groups, including CHAP, apparently, that have some cases. We, in the next Extracorporeal Hours in 2 weeks from now, we'll have two guest speakers, Dr. Buty from Tufts and Dr. Tyler Johnson from North Carolina, and they will share some of their cases of aglatinib toxicity, either whether they treated with hemoperfusion or if they treated with renal replacement therapy because the patient was already in acute kidney injury. So if any of you are interested, like, because I think those are toxicity we're going to see more and more. So definitely in 2 weeks from now, we'll get an insight in the outcomes and the way they've been treated. And Chap, you're welcome to be there and give your input as well.
Awesome. Thanks. That'll be great.
Yeah, I think to wrap up, I mean, Gary, your point, and Jay's kind of getting into this too. It's come up a number of times, like where would be a central list, even if we shared amongst ourselves. If you missed one of these sessions or it hasn't come up, or you're like, what did Chap say that he used on that one talks?
Yeah.
There's a responsibility with it though, because we might just throw anything, and then just because a patient doesn't develop clinical signs doesn't mean the treatment did what it was supposed to do, all the rest of that. So there's somewhere in the middle of, I suppose, anecdotal sharing of those case logs, with some responsibility behind it. And I think that's where when I asked JD about the toxicity list, in the Dialysis Academy too, it's somebody going through with a fine tooth comb. If we're going to publish this, or not publish like literature wise, but to share it, who's making sure the details are appropriate in there, and all of the odds and ends and minutia of it make good sense. So we just have to find that sweet spot, I think. But I do think there's an opportunity for us to share more of our common experiences.
And it's probably going to come down to like a kind of a group of experts going through the evidence and the anecdotal reports, just like the extra and on the human side. But again, and you can tell from the output of that group that it takes a lot of time, and they haven't tackled that many molecules. So it's definitely a challenge.
Well, with that though, Gary, thanks for sharing your AKI case. I'm sorry about the outcome. Chap, appreciate all the input that you put in around the small volume circuits and comparing some of the models. Jay, it sounds like you guys have been busy over there. Maybe you'll want to share your aspirin case down the road a little bit here, and we'll learn a whole bunch about apical tox coming up in a couple of weeks. So thanks, Cedric, for organizing all that in the background. That's a hot topic for sure. All right, guys. Well, if nothing else, I don't know, Cedric, do you want to close us out here, and we'll call it a day?
Again, like a very good session. I like when like we have like very open discussion, even if there's like nothing really structured. Today we'll probably have something a little bit more structured for the next ones, but I like when we just like go with the flow, like today. Very interesting discussions for sure.
All right. Thanks, everybody.
Thanks.